Hello. Hello everyone. Please check my voice. The topic of discussion is hemoglobin chemistry and metabolism. We'll cover the important clinical cases. Cover the important long answer question from this topic. Also, we'll cover the important short notes, that is sickle cell anemia, thalassemia, different types of porphyrias that we will cover in this topic. So this is a thank you Dinesh, thank you Vinay. Hi Raghav. Hello everyone. So this is NMC competencies 6.11, 6.12, and this is one of the important topic for the clinical cases related with the biochemistry. It includes number of 7 to 8 clinical cases which are important for the university examination. Also, these cases can be asked in the as a short note SAQ. For example, sickle cell anemia, thalassemia, their types, then porphyria के types, the congenital hyperbilirubinemia. So this can be asked as SAQ in the university examination. Also, this is favorite topic for the Viva because it is connected with the SGOT, it is connected with the SGPT, it is connected with the bilirubin and also alkaline phosphatase. So, because it is connected with number of practical estimations, SGOT, SGPT, alkaline phosphatase, and bilirubin estimation, it is related. It is also related with the liver function test. So, this topic is important for the Viva, Grand Viva. It is very, very important, and practical Viva, it is also important topic. Okay, so what are the different types of bilirubin? What do you mean by direct bilirubin, indirect bilirubin? So these are the questions the repeatedly asked in the Viva also. So today we'll discuss about the heme synthesis pathway. Bilirubin metabolism means the degradation. Heme synthesis we'll discuss the heme synthesis with important mnemonic to remember the pathway. We'll discuss the different types of porphyrias which are related with the heme synthesis pathway. We'll discuss the bilirubin metabolism, which is even more important than the heme synthesis pathway because it is connected with the jaundice. So that's why it is important. So we'll discuss the different types of jaundice. We'll discuss the sickle cell anemia. We'll discuss the thalassemia. We'll discuss the different types of hemoglobin. So these are the topics of discussion today, and in discussion we'll discuss the important clinical cases. So this is a top priority. आपने सुना होगा कभी कभी मतलब हमारे रिलेटिव्स बताते हैं कि बच्चे का जन्म हुआ तो बच्चे को मतलब वो कांच में रखा है, ऐसा हमको बताते हैं कांच में रखा है ना. सो अगर वो ब्लू कलर के कांच में रखा है, दिस इज फोटोथेरेपी. फोटोथेरेपी टू डिक्रीज द बिलिरुबिन. टू बिलिरुबिन is converted into its non-toxic isomer, that is lumirubin, which is excreted out by the phototherapy by blue light. Giving the blue light, there is conversion of bilirubin into non-toxic excretable form. So that's why it is kept in the blue light. Neonatal jaundice, and jaundice typically appears on the third day of life. So we'll discuss a case of we'll just wait. So hello all of you. Hi everyone. So neonatal physiological jaundice means jaundice typically appears on the third day of life. Typically on the third day of life. Remember, when the jaundice it is within 24 hours after the birth, it is known as pathological jaundice. So most common cause of pathological jaundice is RH incompatibility. Means mother का blood group negative है और बच्चे का पॉजिटिव है. सो इट इज द RH incompatibility and ABO incompatibility. These are the causes, important causes of pathological jaundice. But हमको उससे कुछ लेना देना नहीं है. So neonatal jaundice, physiological jaundice, it appears on the third day because of immature liver to conjugate the bilirubin. Immature system is there, and particularly affect the preterm neonates. It is affected and it appears on the third day of life, and there is increase in the unconjugated bilirubin. So neonatal physiological jaundice for which phototherapy is given. The second important clinical case is sickle cell anemia. The sickled RBC which blocks the vasculature. एक छोटी छोटी आर्टरीज, छोटे छोटे कैपिलरीज को, ये सिकल्ड शेप, नॉर्मली फ्लो नहीं होती बराबर वहां पे माइक्रो कैपिलरीज से या कैपिलरीज से, एंड द डिस्टल टू दैट कैपिलरी, मतलब वहां पे ऑब्स्ट्रक्ट करती, और आगे का पार्ट जो है उसको ब्लड सप्लाई नहीं होता. सो पेन इज द टिपिकल फीचर, पेन इज द प्रिडोमिनेंट फीचर in the sickle cell anemia. So there is jaundice because of rapid hemolysis of the RBCs, there is pain in the extremities. These are the features of sickle cell anemia. And the laboratory tests which are used for the detection of sickled RBCs under the microscope, also the hemoglobin electrophoresis pattern, which is important here in the sickle cell anemia. Then we'll discuss the beta thalassemia major, the important case where hepatosplenomegaly is there, and the typical phases because of abnormal hematopoiesis or hematopoiesis, their bones are involved. So the maxillary overgrowth, frontal bossing will be there, hepatosplenomegaly will be there in the beta thalassemia major. So we'll discuss the case of beta thalassemia major. Then we'll discuss the different types of porphyrias, that is acute intermittent porphyria, congenital erythropoietic porphyria, and porphyria cutanea tarda. These cases we'll discuss. So the predominant symptom in the porphyria is the neurological manifestations and abdominal pain, and some porphyrias where porphyrins are excreted, their photosensitivity is the predominant symptom. So we'll discuss the different type of porphyrias. Then there are congenital hyperbilirubinemia. So in some there is increase in the direct bilirubin, and in some there is increase in the indirect bilirubin. So we'll discuss the congenital increase in the bilirubin level, that is Crigler-Najjar type 1 and type 2, Gilbert, Rotor, and Dubin-Johnson syndrome. So this is topic which is particularly important for the MCQs. Various MCQs are there in the congenital hyperbilirubinemia. कौन से इसमें डायरेक्ट बिलिरुबिन बढ़ता है, कौन से इसमें इनडायरेक्ट बिलिरुबिन बढ़ता है, और कौन से इसमें कौन सा म्यूटेशन है या डिफेक्ट है, ये फ्रीक्वेंटली यहाँ पे congenital hyperbilirubinemia में पूछते हैं. Then the three different types of jaundice, that is prehepatic, hepatic, and obstructive, and how to differentiate between these three types of jaundice. This is important because it is connected with the different enzymes, bilirubin, and the enzymes and bilirubin level. From this means bilirubin level means Vandenberg reaction, we can differentiate between the different types of jaundice. So these are the different clinical cases which are important here. Also sickle cell anemia, thalassemia, porphyria, and jaundice, this can be a short answer question. Jaundice can be a part of LAQ long answer question. It can be asked in the LFT, liver function test. The jaundice cases can be from the enzyme topic, can be from the hemoglobin topic, or can be from the function test. So you may get the jaundice case anywhere from this. So integrated topic, so that's why very important topic. Okay, now see, we'll start with the heme and heme synthesis. We'll start with the porphyrins and heme synthesis. So heme synthesis pathway, it is important. Heme is important. There are number of heme containing proteins, mainly the hemoglobin, which is important. Myoglobin is there. Cytochrome is there. Cytochrome. Then cytochrome P450, which is important in detoxification reaction, is important. Then the tryptophan pyrrolase, it is important. Tryptophan pyrrolase and catalase. These are the important heme containing enzymes. Important heme containing enzymes. So hemoglobin, which is important for the transport of O2 and CO2. Myoglobin is the temporary storage form of the oxygen. Cytochrome, it is required for the electron transport chain, and cytochrome P450, it is required for the hydroxylation reaction in the detoxification process. Tryptophan pyrrolase, it is important for the tryptophan metabolism, and catabolism of H2 to hydrogen peroxide catalase is important. So these are the different heme proteins. Now how heme is produced, what is porphyrin, we'll discuss. See, the porphyrins, पॉरफायरिन्स क्यों आया यहाँ पे पॉरफायरिन्स, हमको तो हीम डिस्कस कर रहे थे, पॉरफायरिन्स कहाँ से आया. सो पॉरफायरिन हीम इज नथिंग बट द प्रोटोपॉरफायरिन 9 विथ आयरन एट इट्स सेंटर. इट इज नथिंग बट द प्रोटो porphyrin 9 with iron at its center. So porphyrins, they are represented by the four close brackets. See, these are the four close brackets. So this is simplified structure of the porphyrin, which is given by the Hans Fischer. So now see, so it is porphyrin, protoporphyrin 9 with iron at its center, iron in the ferrous state. So it is iron which is in the ferrous state. So four pyrrole rings, each bracket, this close bracket, each bracket represents pyrrole ring. Each bracket represent the pyrrole ring. This is pyrrole ring, single pyrrole ring. So it is four pyrrole rings are there and iron in the center. So iron, it is in the it is in a coordinated state of 6 here. Above the plane it is connected with the O2, below the plane it is connected with the histidine of the globin chain. Below the plane it is connected with histidine of the globin chain, and it is connected with the nitrogen of the pyrrole ring, 4 nitrogen of the pyrrole ring. So it is in the coordinated state of 6, and there are 8 substituent position on this pyrrole ring. See, first, second, third, fourth, fifth, sixth, seventh, and 8th substituent position. It is heme is nothing but the protoporphyrin 9 with iron in the ferrous state. So that is heme, protoporphyrin 9 with, it is hemoprotein. Heme is a prosthetic group. So hemoprotein, heme is a prosthetic group. So heme is a protoporphyrin 9 with iron at its center. So 8 substituent position, it is methyl vinyl, methyl vinyl, methyl propionyl, propionyl methyl. These are the 8 substituent positions in the heme. Once again, I will repeat. It is represented by the 4 close bracket. Each close bracket is nothing but the pyrrole ring. It is tetrapyrrole. Iron at its center. Iron is connected with this 4 nitrogen of this pyrrole ring. Above the plane, it is connected with the O2. Below the plane, it is connected with histidine of the globin chain. Histidine of the globin chain. So it is in the coordinated state of 6. Now this substituent position, there are 8 substituent position: मिथिल विनाइल, मिथिल विनाइल, मिथिल प्रोपियोनिल, प्रोपियोनिल मिथिल. सो ये जो असिमेट्री है यहाँ पे, जैसे एमवी एमपी पीएम, ये जो यहाँ पे असिमेट्री है, दैट्स व्हाई इट इज नोन एज porphyrin 3. It belongs to porphyrin 3. अगर ये सब सिमेट्रिकल होता तो it is porphyrin 1. It is porphyrin 1. MV होता तो it is porphyrin 1. This is porphyrin 3 क्योंकि यहाँ पे asymmetry है. Okay, so this is porphyrin. In short, the porphyrins, and porphyrin shows absorption spectra at 400 nanometer. Characteristic absorption spectra at 400 nanometer, that is known as Sorate band. It is known as Sorate band. Porphyrins shows characteristic absorption spectra at 400 nanometer, that is known as Sorate band. This can be a MCQ. This can be a MCQ. Now we'll discuss the important LAQ: heme synthesis, the site of heme synthesis, the steps of heme synthesis, the regulation of heme synthesis, and related disorders means porphyrias. And related disorders means porphyrias. So heme synthesis pathway. So heme synthesis pathway. Heme synthesis pathway. This can be a LAQ long answer question for your university examination. Heme synthesis pathway. Okay. And related disorders means porphyrias. Now heme synthesis, what is the site for the heme synthesis? Here the site for heme synthesis, it is site, it occurs, the first reaction occurs in the mitochondria, and last 3 steps जहाँ पे oxidase चालू होता है वहां से last 3 steps, coproporphyrinogen oxidase, protoporphyrinogen oxidase, and the ferrochelatase. These last three steps and the ALA synthase first step. So these steps occurs in the mitochondria. Rest of the steps occurs in the cytosol. So it is mitochondria plus cytosol. Mitochondria plus cytosol. It occurs in erythroid precursor cells of the bone marrow. Erythroid precursor cells of the bone marrow. 80% synthesis occurs in erythroid precursor cell of the bone marrow, and the remaining occurs in the liver. 80% it occurs in the erythroid precursor cell of the bone marrow. It occurs in all cells of the body except matured RBCs. The heme synthesis occurs in all cells of the body. So erythroid precursor cells of the bone marrow and the liver, these are the major site for the heme synthesis. It occurs in the mitochondria and cytosol. So first step and last three steps, they occurs these steps they occurs in the mitochondria. They occurs in the mitochondria. First step and last three steps occurs in the mitochondria, and the in between these there are steps which occurs in the cytosol. So the regulation of this pathway occurs by the compartmentalization, where the ALA, delta amino levulinic acid, it is transported from mitochondria to cytosol, is the important step in the regulation of this pathway. Also, this pathway is regulated by feedback inhibition and the control at the genetic level by the induction and repression of the ALA synthase enzyme. So rate limiting enzyme of this pathway is the first step. Rate limiting step, it is first step, that is ALA, which is catalyzed by ALA synthase enzyme, and pyridoxal phosphate is required as an coenzyme for this step. ALA synthase is the first step. दूसरी वजह से PLP is also an hematopoietic vitamin. Apart from B12 and folic acid, PLP is also required for the formation of hemoglobin. Okay, so rate limiting is the ALS synthase. Here starting material for the heme synthesis pathway is the glycine and succinyl coenzyme A. Succinyl coenzyme A is an intermediate of TCA cycle. Glycine is an simple amino acid. So glycine and succinyl coenzyme A. One mnemonic to remember here is the some great doctor palpate heart undercover and produces pure heme. So this is mnemonic here. Some great doctors palpate heart undercover and produces pure heme. Some great doctors palpate heart undercover and produces pure heme. This is mnemonic to remember the heme synthesis pathway. So it is very easy pathway. So there is no need to panic here. Just practice this pathway. This is important pathway. Don't do the structures. Structures are not mandatory for you. Just do the pathway. Try to recollect the enzymes. Recollect the enzymes and the disorders which are related with this pathway. Disorders which are related with this pathway. Now see, the glycine, the simple amino acid glycine condenses with intermediate of TCA cycle, that is succinyl coenzyme A. So glycine with succinyl coenzyme A, on condensation there is formation of delta amino levulinic acid. Delta amino levulinic acid on condensation. Glycine plus succinyl coenzyme A. So in this reaction there is release of coenzyme A and there is CO2, it is released. Coenzyme A and CO2, it is released in this reaction. So glycine plus succinyl coenzyme A, there is release of coenzyme reduced coenzyme A and the CO2 here in this reaction. So delta amino levulinic acid, it is produced. So it is the enzyme that is ALA, amino levulinic acid synthase. There are two types of ALA synthase, that is ALA synthase 1 and ALA synthase 2. ALA synthase 1, it is expressed in all cells of the body. ALA synthase 2, it is present in erythroid precursor cells. It is an important rate limiting step in the heme synthesis in the liver, ALA synthase 1, and it is under the feedback inhibition, and it is also induced ALA synthase 1. So what is difference between ALA synthase 1 and 2? This can be a question for the मतलब जिसने वाइवा में बाकी सारे जवाब दिए, फिर एग्जामिनर आपको पूछता है व्हाट इज डिफरेंस बिटवीन ALA synthase 1 and 2. So ALA synthase 1, it is expressed in all cells of the body. 2, it is expressed in the erythroid precursor cell. It is rate limiting step in the liver heme synthesis. Then it is under the feedback regulation of heme, and it is induced ALA synthase 1. ALA synthase 2, it is not induced and it is not under the feedback control. So this is difference between ALA synthase 1 and 2. So here condensation of these two compound will form the delta amino levulinic acid, which is a two-step process. This is a two-step process where there is synthesis of delta amino levulinic acid occurs. Now, two molecules of delta amino levulinic acid condenses on dehydration. There is removal of water molecule. There is removal of water molecule. There is removal of water molecule, and it will give you two molecule of delta amino levulinic acid condenses to form with the help of enzyme ALA dehydratase. ALA dehydratase, and this enzyme is dependent on the zinc. This enzyme is dependent on zinc, and this ALA synthase pyridoxal phosphate is required. Pyridoxal phosphate is required. So two molecules of delta amino levulinic acid condenses to form porphobilinogen. There is formation of porphobilinogen. पूरा नाम लिखता अभी, porphobilinogen. Porphobilinogen. Okay, so this is monopyrrole. There is synthesis of monopyrrole. This parphobilinogen is the monopyrrole. Now see, glycine plus succinyl coenzyme, delta amino levulinic acid, parphobilinogen. Now four molecules of parphobilinogen condenses on deamination by the enzyme parphobilinogen deaminase. So there is parphobilinogen deaminase. The another name of enzyme is hydroxymethylbilane synthase or uroporphyrinogen 1 synthase. These और एक ही नाम है, parphobilinogen deaminase, hydroxymethylbilane synthase or uroporphyrinogen 1 synthase. This will form the hydroxymethylbilane. Hydroxymethylbilane. So four molecules of porphobilinogen condenses and it forms the hydroxymethylbilane. This is deamination reaction, 4NH3 release from this step. So see, glycine plus succinyl coenzyme A form delta amino levulinic acid. Two molecules of delta amino levulinic acid condenses to form to form porphobilinogen. Four molecules of porphobilinogen condenses to form hydroxymethylbilane. अभी देखो यहाँ पे अगर ब्लॉक है, if there is block above this step, there are sirf only abdominal pain and neurological manifestations will be there. In these all condition there is abdominal pain and neurological manifestations will be there if there is block above this synthesis, above the synthesis of hydroxymethylbilane. This is uroporphyrinogen 1. See the name, uroporphyrinogen 1 synthesis. This is uroporphyrinogen 1. So if it is, these porphyrin precursors are produced, once they are produced, there is photosensitivity. इसके नीचे में अगर ब्लॉक है, there is photosensitivity. इसके ऊपर में ब्लॉक है, abdominal pain, neurological manifestations. This is because of heme. It is required for the synthesis of multiple proteins. Heme is a constituent of multiple prosthetic group in multiple proteins, multiple enzymes. It is required mainly the tryptophan pyrrolase. So tryptophan pyrrolase deficiency means it is required for the tryptophan pyrrolase activity. So deficiency of tryptophan pyrrolase diverts the tryptophan for the serotonin production. So there is production of serotonin. Also it affects the number of other inhibitors also affected. That's why there is neurological symptoms and the abdominal pain because of decreased hemoprotein. This is thought to be cause for the neurological manifestations and the that न्यूरोलॉजिकल मैनिफेस्टेशंस एंड एब्डोमिनल पेन. अभी इसके नीचे अगर ब्लॉक है, दिस इज porphyrin precursor. इसके नीचे अगर ब्लॉक है, सो these porphyrins are excited by the light. It is by UV light, it is converted into the porphyrins, and porphyrins they causes the generation of reactive oxygen species, which damages the lysosomes, and release of lysosomal enzymes causes the cutaneous lesions. Photosensitivity can be there. So see, some great doctor palpate heart. Okay, some great doctor palpate hard. Now uroporphyrinogen. Uroporphyrinogen 3. There is production of uroporphyrinogen 3. So hydroxymethylbilane, it is converted into uroporphyrinogen 3. This is linear tetrapyrrole. This is linear tetrapyrrole. This hydroxymethylbilane. On cyclization, on cyclization, this is converted into uroporphyrinogen 3 on cyclization with the help of uroporphyrinogen 3 co-synthase enzyme. Uroporphyrinogen 3 co-synthase enzyme, there is formation of uroporphyrinogen 3. Now cyclization, there is formation of uroporphyrinogen 3. Now see this uroporphyrinogen 3, this is close bracket 4 close bracket, no iron, अभी तक आयरन यहाँ पे आया नहीं है, and there is acetyl group, propionyl group, acetyl, propionyl, acetyl, propionyl, propionyl, acetyl. That's why it is 3. Otherwise, if it is acetyl propionyl group, AP, 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 it is then uroporphyrinogen 1. So this hydroxymethylbilane or uroporphyrinogen 1 synthase with the help of uroporphyrinogen 3 co-synthase, it is converted into uroporphyrinogen 3. So acetyl propionyl, acetyl propionyl, acetyl propionyl and propionyl acetyl, these are the substituent groups. So ये मैंने इसलिए निकाला क्योंकि इसके नीचे के स्टेप्स इस पे डिपेंडेंट है. Now this is uroporphyrinogen decarboxylase enzyme. On decarboxylation, there is release of 4 molecules of CO2. Here these acetyl groups, they are converted into methyl group. So this is product here. So here MP, 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 PM. So this molecule is known as coproporphyrinogen. Porphyrinogen 3. So uroporphyrinogen 3, it is converted into coproporphyrinogen 3. So got the point. Acetyl groups, they are converted into methyl group. There is liberation of 4 molecules of CO2, and here enzyme is uroporphyrinogen decarboxylase. Uroporphyrinogen decarboxylase. Okay. Now coproporphyrinogen, by the coproporphyrinogen oxidase, it is converted into protoporphyrinogen. It is converted into protoporphyrinogen. 9, that is by the coproporphyrinogen CpG. We'll write the CpG. Just wait. Coproporphyrinogen oxidase. Now from this oxidase, so it is mitochondrial oxidase. Oxidation generally occurs in the mitochondria. This is mitochondrial step. So this is coproporphyrinogen 3. It is converted into, by the decarboxylation reaction, it is converted into protoporphyrinogen 9. Now in this, so this propionyl group, these two propionyl group, they are converted into vinyl group. So methyl vinyl, methyl vinyl, methyl propionyl, propionyl methyl will be there. So protoporphyrinogen 9. Now see this. So this is methyl vinyl. So methyl propionyl, propionyl methyl will be there. So this is protoporphyrinogen 9 और by the decarboxylase reaction. फिर से बताता हूँ मैं. See, some great doctors palpate heart undercover produces pure heme. Okay. So succinyl coenzyme है glycine, delta amino levulinic acid, parphobilinogen, hydroxymethylbilane, uroporphyrinogen 3, then coproporphyrinogen 3, then protoporphyrinogen 9. यहाँ तक आए हम produces protoporphyrinogen 9. Now this is oxidase. यहाँ से माइटोकॉन्ड्रिया चालू हो जाएगा. ये फर्स्ट स्टेप जो थी वो माइटोकॉन्ड्रिया में हुई. अभी ऑक्सीडेज से फिर से माइटोकॉन्ड्रिया चालू हो जाएगा. सो कोप्रोपारफेरिनोजेन ऑक्सीडेज ऑन डिकार्बोक्सिलेशन कन्वर्ट्स दिस propionate into 2 propionate into vinyl group. So MV, MV, MP, PM is there. This molecule is protoporphyrinogen 9. Now this protoporphyrinogen 9, it is converted into protoporphyrin. It is converted into protoporphyrin. It is by the protoporphyrinogen oxidase. Protoporphyrinogen oxidase, it is converted into protoporphyrin. And this protoporphyrin, on incorporation of the iron, it is converted into, this is iron, on incorporation of iron, it is converted into heme molecule. Heme. Here the enzyme is heme synthase. Heme synthase or ferrochelatase. Another name is ferrochelatase. Heme synthase or ferrochelatase. Okay. So these are the steps in the heme synthesis. This is delta amino levulinic acid. 2 molecules of delta amino levulinic acid in presence of dehydratase. सो जिंक इसको भी लगता है, जिंक हीम सिंथेस को भी लगता है लास्ट रिएक्शन को, और ये दोनों लीड से इनिबिट होते हैं. लीड इनिबिट एएलए डिहाइड्रेटेज, लीड इनिबिट एएलए सिंथेस. सो दैट्स व्हाई देयर इज inhibition in the chronic lead toxicity, that is plumbism or plumboporphyria, it is known as. So in the plumbers it is lead toxicity. So lead toxicity that inhibits the zinc activity and it inhibits the ALA dehydratase and the heme synthase enzyme. So lead causes the uh, anemia. So lead inhibit this ALA dehydratase activity. Now 2 molecules of delta amino levulinic acid form the parphobilinogen. 4 molecules of parphobilinogen on deamination form hydroxymethylbilane. Hydroxymethylbilane, it is converted into uroporphyrinogen 3 on cyclization. It is converted into uroporphyrinogen 3. It is converted into, by the decarboxylation, this acetyl group is converted into methyl group. Uroporphyrinogen is converted into coproporphyrinogen. Then again by the coproporphyrinogen oxidase, it is converted into protoporphyrinogen, and protoporphyrinogen is converted into protoporphyrin, and protoporphyrin, on incorporation of iron in the ferrous state, it is converted into heme. Heme is nothing but the protoporphyrin 9 with iron at its center. With iron at its centers. Two important sites, erythroid precursor cells and the liver. Important rate limiting step is the first step, which is catalyzed by the ALA synthase. There are three modes of regulation of this pathway. Three modes of regulation of this pathway. ALA synthase is the important rate limiting step, that is delta amino levulinic acid synthase The first step is the regulatory step, which requires pyridoxal phosphate as coenzyme. Now, how it is regulated? It is under the feedback inhibition. This heme inhibit the ALA synthase. So it is first is the feedback inhibition. Feedback inhibition means the last product. Last product of the pathway means heme inhibit the ALA synthase activity. This is feedback inhibition. Second, this second is the induction and repression. Actually, it is repression mainly. Repression. Repression. So heme represses the synthesis of ALA synthase at the genetic level by the inhibiting the transcription and translation process. Heme inhibit the repression of ALA synthase. So this is at the genetic level. And third one is the compartmentalization, the transport of delta aminoleucinic acid from mitochondria to cytosol. It is regulated process and it is regulated by the heme. So transport of delta aminoleucinic acid from mitochondria to cytosol, it is regulated by the heme. So by these three mechanism, this pathway is regulated. This pathway is regulated by these three mechanisms. Now the disorders and how to remember the disorders. Now see, there are a lot of disorders which are known as porphyrias. Porphyrias. So see, so ALA synthase defect causes the anemia. So that is known as the X-linked sideroblastic anemia. That is known as X-linked sideroblastic anemia. Lead toxicity also causes the anemia and it can cause the abdominal pain and neuropsychiatric manifestations because lead inhibit two enzyme ALA dehydratase and and heme synthase, that is ferrochelatase. Now this causes acute intermittent porphyria, deficiency of this UPG1, uroporphyrinogen 1 synthase causes acute intermittent porphyria. So there is abdominal pain and neuropsychiatric manifestations in the acute intermittent porphyria. All porphyrias, they are autosomal dominant except congenital erythropoietic porphyria and the protoporphyria. Also this is X-linked sideroblastic anemia. This is anemia is the X-linked sideroblastic anemia. But most of the disorders, they are autosomal dominant. Autosomal dominant. Then the uroporphyrinogen 3 co-synthase defect, it causes congenital erythropoietic porphyria. Congenital erythropoietic porphyria. So here onward from the congenital erythropoietic porphyria, because there is accumulation of this is UPG, uroporphyrinogen. Uroporphyrinogen, they are converted into porphyrins and that can cause the there is synthesis of porphyrins which causes the generation of free radicals, reactive oxygen species, that damages the lysosomes and release of lysosomal enzymes causes the cutaneous manifestations, skin manifestations, blistering skin lesions. So it is photosensitivity is the predominant symptom in the congenital erythropoietic porphyria. Also this can be wood lamp examination of urine shows the red fluorescence. Also wood lamp examination of the teeth shows the red fluorescence, that is known as the erythrodontia in the congenital erythropoietic porphyria. This because of repeated photosensitivity, repeated lesions, scarring and hairs. Repeated scarring and hairs, this gives the ugly look. So they looks like werewolf. ऐसा बोलते थे कि they looks like werewolf. और फोटो सेंसिटिव होने के वजह से वो रात में घूमते, ये जो लोग रहते थे ये रात में घूमते. सो वैम्पायर भी बोलते हैं उनको, वैम्पायर और वेयरवुल्फ का रीजन क्या है? बिकॉज ऑफ रिपीटेड स्कारिंग, लीजन एंड स्कारिंग गिव्स द अगली लुक. ऑल्सो द फेशियल हेयर्स आर देयर and their nocturnal activity that gives the name vampire because of photosensitivity. धूप में जाएंगे तो जल जाएंगे, like that. So vampire like activity, so they are known as the vampire and werewolves. Okay, so like appearance in the congenital erythropoietic porphyria, or also known as Gunther's disease. So erythrodontia, red fluorescence of the teeth, red fluorescence of the urine, it is because of excretion of the porphyrins, and photosensitivity is the predominant manifestation in the congenital erythropoietic porphyria. So uroporphyrinogen decarboxylase, it causes the Porphyria cutanea tarda, which is the most common porphyria, and it is characterized by bullous, larger skin lesions, Porphyria cutanea tarda, uroporphyrinogen decarboxylase defect. Then Coproporphyrinogen oxidase defect causes the hereditary coproporphyria. Hereditary coproporphyria. The protoporphyrinogen oxidase defect causes the variegate porphyria, and this is the defect ferrochelatase or heme synthase defect causes the protoporphyria. So protoporphyria. Okay. So all the यहाँ से नीचे जो भी डिफेक्ट है, there is photosensitivity in all these defects. As there is interconversion into the uroporphyrinogen 1 also, this can be, there can be a there is abdominal pain in the hereditary coproporphyria and the variegate porphyria, and neurological symptoms are also there. But photosensitivity is mainly below this hydroxymethylbilane point. ये इसके नीचे में photosensitivity है, इसके ऊपर में photosensitivity नहीं है. So these are the different porphyrias related with the heme synthesis pathway. So generalization, now see, revision. The pathway occurs in the mitochondria and cytosol. First step mitochondria, last three steps mitochondria, rest of the steps in the cytosol. जहां से ऑक्सीडेज चालू होता नीचे में, वहां से माइटोकॉन्ड्रिया. रेट लिमिटिंग स्टेप ALA synthase, starting material glycine and succinyl coenzyme A, occurs in the erythroid precursor cell and the liver. These are the sites, mainly 80% in the erythroid precursor cell. Synthesis occurs in all cells of the body except matured erythrocytes. These are the steps in the synthesis. Glycine succinyl coenzyme form delta amino levulinic acid. Two molecules of delta amino levulinic acid on dehydration gives porphobilinogen. This is monopyrrole, मतलब single pyrrole ring बनती है यहाँ पे. This is monopyrrole. After the synthesis of porphobilinogen, there is 4 molecule of porphobilinogen condenses on deamination. They form the hydroxymethylbilane. This is the first porphyrinogen which is produced, that is known as uroporphyrinogen 1. Hydroxymethylbilane, it is converted into on cyclization. This is linear tetrapyrrole. 4 pyrrole connected रहते लेकिन linear रहते. Cyclization form the uroporphyrinogen 3. Uroporphyrinogen 3 is converted into coproporphyrinogen 3, which is converted into protoporphyrinogen 9, which is converted into protoporphyrin, and which is converted into heme. 3 regulatory steps. Means ALA synthase activity is regulated by the 3 mechanism. First one is the feedback inhibition, where heme inhibits the ALA synthase activity. Repression and derepression, it is by the heme. Heme causes the decreased synthesis of ALA synthase at the genetic level. So decreases the synthesis of the transcription and translation of ALA synthase. And the transport of delta amino levulinic acid from mitochondria to cytosol, it is a regulatory process. It is regulated by the heme. Different types of porphyrias are there: hepatic porphyrias and the erythropoietic porphyrias. It is dependent on the defect in which enzyme is dependent on the organs in which enzyme is defective. If it is in the liver, it is known as the hepatic porphyrias. The 4 are important hepatic porphyrias, that is acute intermittent porphyria, porphyria cutanea tarda, hereditary coproporphyria, and variegate porphyria. These are the hepatic porphyrias, while congenital erythropoietic porphyria and protoporphyria, these are the erythropoietic porphyria. So you may get a short note on the porphyria. Okay, ये भी डिस्कस करेंगे, just wait. C2 and C8 of the purine, इसका स्ट्रक्चर फिर से देख लेना. इसका पूरा ये देखना, C2 it is by the formyl tetrahydrofolate, and C8 C8 it is by the methynyl tetrahydrofolate. Remember this can be a MCQ. So N5 N10 भी लगा हुआ रहेगा आगे, हाँ, N5 N10. ओके. और इस पे MCQ भी आता है इस पे, ठीक है. मितांशु, आप प्यूरिन न्यूक्लियोटाइड सिंथेसिस में जा रहे हो। यू आर कंफ्यूजिंग विद द प्यूरिन न्यूक्लियोटाइड सिंथेसिस। हिम सिंथेसिस अलग है, प्यूरिन न्यूक्लियोटाइड सिंथेसिस अलग है। Okay. Now see porphyrias, the disorders in which porphyrins are excreted in the urine, they are known as the porphyrias. It can be inherited and acquired. It can be inherited, acquired. Inherited because of the defect in the enzymes of heme synthesis. If these enzymes are defective, it can causes inherited porphyria. But porphyrias can be acquired. For example, the renal diseases, liver diseases, specific tumors, and the toxins, that is mercury, arsenic, lead. Mercury, arsenic and lead toxicity also causes the porphyria, so can be acquired. Okay, so the inherited porphyrias, these are due to the defect in the heme synthesis enzymes. So these are the three important one: acute intermittent porphyria, porphyria cutanea tarda, एंड कंजेनाइटल इरिथ्रोपोइटिक पॉर्फायरिया, और तीनों सीक्वेंस में है। एक्यूट इंटरमिटेंट पॉर्फायरिया, कंजेनाइटल इरिथ्रोपोइटिक पॉर्फायरिया एंड पॉर्फायरिया क्यूटेनिया टार्डा, ये तीन इंपॉर्टेंट है, वर्थ टू रिमेंबर थ्री। और तीनों का एंजाइम डिफेक्ट जो है, दैट इज, सी, एंजाइम डिफेक्ट इज, सो दिस इज porphobilinogen. So enzyme defect is U1, U3 and UD. U1, U3, UD, uroporphyrinogen 1 synthase, uroporphyrinogen 3 co-synthase, and uroporphyrinogen decarboxylase. U1, U3, U3, U1, U3, UD. Okay, uroporphyrinogen 1 synthase, uroporphyrinogen 3 co-synthase, and uroporphyrinogen decarboxylase. Porphyria, acute intermittent porphyria, congenital erythropoietic porphyria, porphyria cutanea tarda. These three can be asked in the clinical case. In the clinical cases can be there on these three porphyrias. So there is neuropsychiatric manifestation and abdominal pain in the acute intermittent porphyria. Because of photosensitivity, when porphyrin precursors are produced on exposure to UV light, they are converted into porphyrins. Porphyrins causes the generation of reactive oxygen species that damages the lysosomes, and release of lysosomal enzymes causes the skin lesions, cutaneous manifestations, that is known as photosensitivity. So in the porphyria cutanea tarda, the blistering skin, bullous skin lesion, बड़े बड़े skin lesions रहेंगे porphyria cutanea tarda में. Then hereditary coproporphyria and variegate porphyria, in these two there are all three symptoms will be there, that is abdominal pain, photosensitivity, neuropsychiatric symptoms. Abdominal pain, photosensitivity, neuropsychiatric symptoms will be there. Here onward, मतलब acute intermittent porphyria छोड़ दिया तो बाकी सब में photosensitivity common है. Okay. Now congenital erythropoietic porphyria, it is known as Gunther's disease, and it is because of uroporphyrinogen 3 co-synthase defect. There is erythrodontia, red fluorescence on wood lamp examination, and urine also shows the red fluorescence on in wood lamp examination. So because of porphyrins excretion, congenital erythropoietic porphyria. All porphyrias are autosomal dominant except congenital erythropoietic porphyria, also protoporphyria, and the X-linked sideroblastic anemia due to the ALA synthase defect. So congenital erythropoietic porphyria and protoporphyria, these are the erythropoietic porphyria, and these are the hepatic porphyrias. Now see the clinical cases. The important clinical cases for remembering the symptoms of that disease. An 8-year-old boy brought to the hospital with photosensitivity. Photosensitivity है मतलब acute intermittent porphyria नहीं है. Acute intermittent porphyria नहीं है. Okay, photosensitivity and spontaneous development of blisters on the sun exposed area of the body. Spontaneous development of blisters on sun exposed part of the body. On examination, there were many scars on the body. There were more hair on face, shoulder and arms. The teeth were red, and wound lamp examination of urine showed red fluorescence. Red fluorescence. Laboratory investigation showed a decrease in the activity of uroporphyrinogen 3 co-synthase. अभी यहाँ पे decrease activity अगर बोला है, so this disease is here because of decrease. ये तो clear cut दिया है, uroporphyrinogen 3 co-synthase means it is a which disorder, which disorder, कौन कौन है, देख कौन रहे, चलो बताओ कौन सा डिसीज रहेगा. इट इज congenital erythropoietic porphyria, erythrodontia, passage of red urine, Gunther's disease, werewolf-like appearance. It is a congenital erythropoietic porphyria. Also, porphyria cutanea tarda, the same symptoms will be there. Porphyria cutanea tarda, सिर्फ except there are bullous skin lesion, थोड़े से बड़े lesion रहते हैं. It is very difficult to differentiate between all these porphyrias. Now the see, a 45-year-old male presented with skin lesions in the form of tense bully over the extensor aspect of hands, forearm and feet. There was history of photosensitivity and peeling of skin on minor trauma. Physical examination revealed erosions and scars on sun exposed part of the body. Complete photosensitivity is given. The laboratory investigation showed a decrease in the activity of uroporphyrinogen decarboxylase. So there is a decreased activity of uroporphyrinogen decarboxylase. So this indicates, so bullous skin lesions, the larger skin lesion and easily breakable erosions are there. So bullous skin lesion involving the extensor aspect of hand, forearm and feet and decreased activity of uroporphyrinogen decarboxylase indicates the porphyria cutanea tarda. Okay. So in erythropoietic porphyria, there is erythrodontia, there is passage of red urine, there is repeated scarring. स्किन लीजन तो सेम ही रहेंगे लगभग, लेकिन porphyria cutanea tarda में थोड़े बड़े लीजन्स रहते हैं. Acute intermittent porphyria abdominal pain, neurological manifestations. Hereditary coproporphyria में तीनों रहेंगे, varicate porphyria में तीनों रहेंगे, abdominal pain, neurological manifestations and the photosensitivity. A psychiatric patient came to hospital. Psychiatric patient. Psychiatric means neurological manifestation. Repeatedly for abdominal pain. Repeatedly आ रहा वो for the abdominal pain. On investigation, ALA, aminolevulinic acid and parpobilinogen are elevated in the blood and urine. The pain was intermittent and vague. What is diagnosis? There is no photosensitivity. इसमें भी फोटोसेंसिटिविटी रहती, इसमें भी फोटोसेंसिटिविटी रहती, इसमें भी फोटोसेंसिटिविटी रहती. Here answer is acute intermittent porphyria. There is excretion of ALA and parpobilinogen in the urine. Acute intermittent porphyria. Abdominal pain, neurological manifestations. So ये छोड़ दो अभी. Now we'll discuss the important, that is bilirubin metabolism, important topic. Bilirubin metabolism. Heme degradation and bilirubin metabolism. This is important topic. Bilirubin metabolism, heme degradation. So यहाँ पे bilirubin metabolism is the important one. It can be a LAQ when it is asked along with the jaundice. It can be a LAQ long answer question. It is also important for the practical examination. Bilirubin metabolism. So Viva can go in the theoretical part also. So it is very important topic. Bilirubin, heme degradation pathway or bilirubin synthesis or bilirubin metabolism. How bilirubin is produced in our body, how it is transported, how it is transported, what is the meaning of direct bilirubin, indirect bilirubin or conjugated, unconjugated bilirubin, and in which disorders the bilirubin level increases. So neonatal physiological jaundice, the three major types of jaundice, that is prehepatic, hepatic and post-hepatic jaundice, also known as hemolytic, hepatic and the obstructive jaundice. And few causes the congenital increase in the bilirubin level, that is Crigler-Najjar type 1, type 2, the Gilbert syndrome, Rotor syndrome and the Dubin-Johnson syndrome. These are the important cases related with the bilirubin metabolism. So we'll start with the bilirubin. See, in the bilirubin metabolism, it is a product of heme degradation pathway where hemoglobin is broken down into heme and globin. It is broken down into heme and globin, Globin is converted into amino acids and it is reutilized. It is converted into amino acid and it is reutilized. The degradation of heme, it occurs in the reticuloendothelial system, that is spleen, liver and bone marrow. It occurs in the macrophages. It occurs in the macrophages of reticuloendothelial system, spleen, liver and bone marrow. Spleen, liver and bone marrow, where heme is converted into biliverdin, biliverdin is converted into bilirubin. Heme is converted into biliverdin, biliverdin is converted into bilirubin. So we'll discuss the pathway of heme degradation. So heme, it is converted into biliverdin, which is green colored compound biliverdin. Here name of the enzyme is heme oxygenase. Heme oxygenase is the enzyme. Three molecules of O2 they are required. Three molecules of O2 they are required, and NADPH is required. NADPH. Three molecules of O2 and 7 electrons they are required. The electrons they are provided by the NADH and NADPH reductase. They provides the electron for this step. This O2 that cleave the methynyl bridge in the heme. So this bridge, methynyl bridge, it is broken down by the oxygen. So O2 and NADPH they are required for this reaction for the heme oxygenase, and there is release of the ferric iron in the ferric state, and this is the reaction which is endogenous source of carbon monoxide. Endogenous source of carbon monoxide. So heme is converted into biliverdin with the help of heme oxygenase enzyme, and this biliverdin it is converted into the yellow orange colored pigment, that is bilirubin. Bilirubin. This is converted into bilirubin. Here enzyme is biliverdin reductase. Biliverdin reductase. So NADPH dependent step, NADPH is required, where biliverdin is converted into bilirubin. So methynyl bridge in between third and fourth, uh, in between the pyrrole ring there is methynyl bridge which is converted into methylene bridge in the bilirubin molecule. So see, hemoglobin it is degraded into heme and globin. Globin is converted into amino acid and reutilized. Heme degradation it occurs in the reticuloendothelial system, specifically in the macrophages of reticuloendothelial system. Heme is converted into heme oxygenase by the O2 cleave the methynyl bridge, and this cyclical compound it is converted into the biliverdin with the help of NADPH dependent heme oxygenase enzyme. The ferrous it is really the iron it is released in the ferric state, and this is the only reaction where endogenous carbon monoxide production occur. So CO release occur. Biliverdin by the biliverdin reductase, which is NADPH dependent, biliverdin is converted into yellow colored compound, that is bilirubin. It is converted into yellow colored compound, that is bilirubin. Now bilirubin it binds with the albumin. It How it is transported in the blood? So it bounds to the albumin and forms the albumin bilirubin complex. So albumin bilirubin complex it is transported in the blood. Albumin bilirubin complex. So bilirubin which is produced here it is known as unconjugated bilirubin, which is toxic and water insoluble form. Toxic and water insoluble form. So biliverdin is converted into bilirubin. This is known as unconjugated bilirubin. It is traveled in the blood, incorporated with the albumin. Albumin has two important sites. Albumin has two important sites, that is high affinity binding sites, high affinity binding sites and low affinity binding sites. High and low affinity binding sites of the albumin. The capacity of high affinity binding site is 25 milligram per deciliter. This can be MCQ 25. This is 25. 25 milligram per deciliter. This is capacity of albumin, means high affinity sites of the albumin. 25 milligram per deciliter bilirubin can bind to the high affinity site of the albumin, and rest of the bilirubin it binds to the low affinity site. This is the capacity of high affinity site, and the bilirubin can attach to the low affinity site in the disease state, or when the bilirubin levels are high from the low affinity site, can easily diffuse into the surrounding tissues. This from the low affinity side, it can be easily diffused into surrounding tissues in the pathological state. Okay, so this is the capacity of high affinity sites of the albumin to binds with the bilirubin. This is important MCQ. So to the albumin, bilirubin is transported in the blood. Now it is taken up by there are three processes in the bilirubin metabolism. First one is the uptake. This is by the facilitated diffusion. First is by the uptake of bilirubin by the hepatocytes. Uptake of bilirubin, this is unconjugated bilirubin by hepatocytes, by hepatocyte. This is the first. Second is the conjugation, of bilirubin by the UDP glucuronil transferase. And the third step is the secretion into bile canaliculi. This is rate limiting step, that is secretion into bile canaliculi. Bile. These are the three steps in the bilirubin metabolism. फिर से repeat करता हूँ. See, heme, by the action of heme oxygenase, O2 and NADPH, they are required. They cleave the ring. Heme is converted into biliverdin, which is a green colored compound. Biliverdin, by the biliverdin reductase, it is converted into bilirubin, which is yellow orange colored compound. It is unconjugated bilirubin. This is traveled in the blood, bound to the albumin bilirubin complex. So albumin has two sites, high affinity and low affinity binding sites. To this albumin sites, bilirubin will attach and it is transported in the blood. It reaches the liver, where there three processes are important. Uptake of bilirubin by the hepatocyte. This is by the facilitated diffusion, and this is not a rate limiting step in the bilirubin metabolism, and it has very high capacity. Now see, albumin bilirubin, which is transported in the blood. Suppose this is endothelial surface and it is transported in the blood. So bilirubin, it is taken up by the hepatocytes. It is taken up by the hepatocytes by the process, by the carrier mediated process, and this process is known as facilitated diffusion. Facilitated diffusion, carrier mediated transport, facilitated diffusion. So bilirubin is internalized into the hepatocyte. It is internalized into hepatocyte, and it prevents the reflux of bilirubin from the hepatocyte. It is prevented by the glutathione S transferase enzyme, also known as ligandin. Glutathione S transferase, ligandin, and the protein Y. These are the two proteins which are important for preventing the efflux of bilirubin out of the hepatocytes, and it prevents the bilirubin in the solubilized state than the unconjugated bilirubin which is out there. So these are two functions of this protein. So bilirubin, once in the hepatocyte, it is conjugated with the help of UDP glucuronil transferase enzyme. So conjugation is the second step, in which bilirubin combines with this this is now the unconjugated bilirubin. It condenses with UDP glucuronate in presence of enzyme UDP glucuronil transferase. It forms bilirubin monoglucuronide. So bilirubin is converted into bilirubin monoglucuronide, which is again converted into bilirubin diglucuronide by the same process. It is converted into bilirubin diglucuronide. So bilirubin monoglucuronide, with the help of two molecules of UDP glucuronate. Here UDP glucuronate, which is from the uronic acid pathway, with the help of this enzyme UDP glucuronyl transferase, UDP glucuronyl transferase enzyme, it is converted into bilirubin diglucuronide. And this molecule bilirubin diglucuronide, it is known as conjugated bilirubin. This is conjugated bilirubin. Conjugated bilirubin. So this was unconjugated bilirubin, which is taken up by the hepatocyte. Now in hepatocyte there is conjugation occurs. So this toxic non-soluble unconjugated bilirubin, water insoluble unconjugated bilirubin, it is converted into water soluble excretable form, that is known as conjugated bilirubin. It is by the UDP glucuronyl transferase enzyme, and the attachment of UDP glucuronate is important. So this is known as conjugation process. This is conjugation process. This is second is the conjugation process. First is the uptake. First is the uptake by the hepatocyte, second is the conjugation, and third is the secretion into the bile. Third, this is a rate limiting step in the bilirubin metabolism, secretion into bile. This is rate limiting step. In this step, there is one transporter, that is MRP2, also known as multi or multi-specific organic anion transporter, multi-specific organic anion transporter, or multi-drug resistant protein 2, or also known as ABCC2, also known as ATP binding cassette transporter C2, which is important for secretion of bilirubin into bile canaliculi. So entry into the bile, it is important. Secretion into bile canaliculi. So this is important. MRP2 is required for this. So this conjugated bilirubin from the liver, it enters the bile via the active process. This is active secretion, active transport, energy required for this process, active transport via the carrier protein, that is MRP2. Some escape this transport, and via MRP3 they enters the portal circulation. Via MRP3 they enters the portal circulation, and then it is conjugated bilirubin. It is again taken up by the hepatocytes. This which escapes this part, active transport via the MRP2, enters into the portal circulation via MRP3, and enters into portal circulation. This conjugated bilirubin, unconjugated nahi bol raha main, conjugated bilirubin, it is taken up by the it is taken back by the hepatocyte. Conjugated bilirubin, ये unconjugated था. Conjugated bilirubin, it is taken by the organic anion transporter 1B1, 1B3. This is important, that's why I taken this point. So conjugated bilirubin, which is in the circulation, it is taken up by the hepatocyte with the help of organic anion transporter 1B1, 1B3. Okay. So this is active transport where it is secreted into bile. Now it reaches the intestine, that is colon, ileum and colon. It reaches intestine by the intestinal bacteria, by the intestinal enzymes. The colonic bacteria converts this conjugated bilirubin into urobilinogen. It is converted into urobilinogen. It goes to the kidney where it is converted into urobilin and excreted in the urine. And it goes to the feces in the form of stercobilinogen. This is how transport of bilirubin occurs. Now see this. Heme is converted into biliverdin. Biliverdin is converted into bilirubin. This is unconjugated bilirubin. It is transported in blood bound to the albumin. It liver where conjugation occurs. So conjugation occurs, and through bile it enters the small intestine, large intestine. So in the intestine, this conjugated bilirubin is converted into urobilinogen, and from this intestine, some through the enterohepatic circulation, some bilirubin, it goes to the circulation, and from circulation it goes to the kidney where it is urobilinogen. It is converted into urobilinogen. So already urobilinogen is there. So urobilinogen is converted into urobilin and excreted in the urine. Large intestine, the bilirubin is converted into stercobilinogen and excreted in the feces. So this is how bilirubin metabolized in our body. Now see, if there is now the congenital hyperbilirubinemia, The Krigler-Najar type 1, type 2. Krigler-Najar. Krigler-Najar. Type 1, type 2. Type 1 is the complete deficiency, 2 is the partial deficiency. Only 10% activity is retained. Up to 10% activity is retained. Uh, it is known as the type 2. Okay. Krigler-Najar, complete absence of UDP glucuronil transferase. This is absent in type 1 and partial deficiency in the type 2. So in this disorder, the bilirubin can go, so particularly in the type 1, bilirubin can go beyond 20 milligram per deciliter, and this is toxic. It causes the kernicterus. When it crosses the blood brain barrier, it crosses the blood brain barrier, enters in the brain, and this unconjugated bilirubin, आपने बायोलॉजिकल ऑक्सीडेशन या इलेक्ट्रॉन ट्रांसपोर्ट चेन जब पढ़ा, तो आपने फिजियोलॉजिकल अनकपलर के नाम पढ़े, उसमें एक नाम था अनकॉन्जुगेटेड बिलिरुबिन, हाई लेवल्स ऑफ अनकॉन्जुगेटेड बिलिरुबिन. So unconjugated bilirubin is the uncoupler. It decreases the ATP production. It delinks the ATP electron transport chain from oxidative phosphorylation, and it is toxic. That's why this is a toxic condition and lethal condition. Complete deficiency of UDP glucuronil transferase. In partial deficiency of UDP glucuronil transferase, 20% activity means it is below 20 milligram per deciliter. Bilirubin goes up, but it is below 20 milligram per deciliter, and UDP glucuronil activity is retained here in 10% activity. It is retained. Now, if there is mutation in this MRP2, this causes the Dubin-Johnson syndrome. Dubin-Johnson syndrome, where there is increase in the congenital conjugated bilirubin occurs. There is increase in the conjugated bilirubin in the Dubin-Johnson syndrome. If there is mutation in this organic anion transporter, this causes the Rotor syndrome. This causes the Rotor syndrome. So Krigler-Najar type 1, type 2, there is deficiency of UDP glucuronil transferase activity. Dubin-Johnson syndrome, there is defect in MRP2. Rotor syndrome, there is defect in organic anion transporter 1B1, 1B3. तो ये बता देता मैं, just wait. See this. So congenital increase in the bilirubin level. There are two important conditions. In one, there is increase in the indirect bilirubin. In one, there is increase in the indirect bilirubin. इसको indirect इसलिए बोलते हैं क्योंकि ये डायरेक्ट कलर नहीं देता. जब हम रिएक्शन करते हैं तो इट टेक्स सम टाइम, एंड सोलुबलाइजर आल्सो नीडेड टू मेक द कलरफुल, द सॉल्यूशन कलरफुल. एक मिथेनॉल नहीं तो कैफीन डालना पड़ता, विच इज एज ए सोलुबलाइजर, and the reaction is not immediate, so that's why it is known as indirect Vandenberg reaction. So अनकॉन्जुगेटेड हाइपरबिलिरुबिनेमिया, इंक्रीज इन द इनडायरेक्ट बिलिरुबिन के दो कॉजेस है. ये आपको एमसीक्यू पूछा जा सकता है. वन इज क्रिगलर-नजर टाइप 1 and one is Gilbert. So Krigler-Najar type 1, type 2 and Gilbert. These are the two conditions in which indirect bilirubin increases, means Vandenberg reaction is indirect positive. So here in the type 1 there is complete deficiency of UDP glucuronil transferase, and it is severe condition in which bilirubin go more than 20 milligram per deciliter in this condition. More than 20 milligram per deciliter in this condition. This is a milder form. Type 2, it is a milder form. There is partial deficiency of UDP glucuronil transferase, and bilirubin can go up to 20 milligram per deciliter. So there is kernicterus. So bilirubin, unconjugated bilirubin crosses the blood-brain barrier, and as it is uncoupler, it decreases the ATP production and it is toxic. Gilbert disease, bilirubin can go up to 4 milligram per deciliter. It is mild condition. 4 milligram per deciliter. 33% activity of UDP glucuronil transferase, it is retained in this disorder. There is decrease in the uptake of bilirubin in the liver. There is defect in the uptake of bilirubin by the liver in the Gilbert syndrome. Now these are the causes of increase in the direct bilirubin or conjugated bilirubin. One is the Dubin-Johnson and second one is the Rotor. Dubin-Johnson, it is due to mutation in MRP2 protein. MRP2 protein mutation, it causes Dubin-Johnson syndrome. MRP2 is required for the active secretion of bilirubin into bile canaliculi, and defect in MRP2 causes defective excretion of conjugated bilirubin, and it is characterized by black colored liver. So it is also known as black colored jaundice or black colored liver is there. This is thought to be because of accumulation of metanephrine, epinephrine, metanephrine metabolite, black colored liver. And this can be MCQ. Okay, this can be MCQ. This is MCQ. Then rotor syndrome, it is also a indirect hyperbilirubinemia. There is increase in the direct bilirubin. So direct hyperbilirubinemia. Remember, these are the causes of direct hyperbilirubinemia, and this can be MCQ. So DR, doctor, DR, direct. Dubin Johnson, rotor, direct hyperbilirubinemia. There is increase in the direct bilirubin. Dubin Johnson, rotor, direct, DR, direct bilirubin increase, DR, Dubin Johnson, rotor syndrome. In rotor syndrome, there is mutation in organic anion transporter 1B1 and organic anion transporter 1B3. And in this disease, there is defective excretion of conjugated bilirubin and there is no staining of the liver. No black color is there in the rotor syndrome. So these are the congenital causes of increase in the bilirubin. This is conjugated bilirubin increase. This is increase in the unconjugated bilirubin. This is increase in the conjugated bilirubin. Unconjugated bilirubin in the Krigler-Najar and Gilbert, and the conjugated bilirubin means direct bilirubin in the DR, Dubin-Johnson rotor. These are the congenital causes. यहाँ पे आपको MCQ आ सकता है. This is due to UDP glucuronil transferase activity defect. This is decreased uptake of bilirubin by the hepatocytes. This is problem in the excretion because of mutation in MRP2. Rotor, it is because of mutation in organic anion transporter 1B1 and 1B3, which is required for uptake of conjugated bilirubin by the hepatocytes. So these are the congenital hyperbilirubinemia, can be a MCQ, important. Now three types of jaundice: hemolytic, hepatic and obstructive jaundice. Hemolytic means before liver, because of rapid hemolysis of RBC, there is breakdown of heme occurs and that causes the increase in the bilirubin level, that is hemolytic jaundice. Hepatic means the hepatic causes, for example viral hepatitis or toxins or cirrhosis of liver that affect the liver, so hepatic causes. And obstructive means obstruction to the flow of bile, that is common bile duct stone, CBD, common bile duct stone, stricture, tumor, tuberculosis of the common bile duct or carcinoma of the head of the pancreas. These are the causes of obstructive jaundice. So all these enzymes, they are normal in the hemolytic jaundice. SGOT, SGPT, alkaline phosphatase, gamma glutamyl transferase, 5' nucleotidase. All these enzymes are normal in the hemolytic jaundice. While this in the hepatic jaundice, there is hepatocellular jaundice, there is marked increase in the SGOT and SGPT level. So it can be 2000, 3000, 4000 international unit per liter SGOT, SGPT. Hepatic enzymes, SGOT, SGPT, there is marked increase and slight increase activity of alkaline phosphatase, GGT and 5' nucleotidase. Slight increase in the activity. But in obstructive jaundice, there is slight increase in SGOT and SGPT, but marked increase activity in the alkaline phosphatase, GGT, and the 5' nucleotidase. So these are the obstructive pathology. Alkaline phosphatase, it is present, it is ectoenzyme present on outer surface of biliary canaliculi, and when there is regurgitation to the flow of bile, it irritates the bile canaliculi that causes release of ALP into the circulation. That's why in the obstructive jaundice, alkaline phosphatase level increases. So this is enzymatic pattern. Then the Vandenberg reaction. Vandenberg reaction बाइफेजिक मतलब दोनों पॉजिटिव है, मतलब डायरेक्ट भी बढ़ा हुआ है, इनडायरेक्ट भी बढ़ा हुआ है. ये होता है इसमें डायरेक्ट भी बढ़ा हुआ है, इनडायरेक्ट भी बढ़ा हुआ है हिपैटिक जॉन्डिस में. हिपैटिक जॉन्डिस में दोनों बढ़ते हैं. ऑब्स्ट्रक्टिव जॉन्डिस में डायरेक्ट बढ़ता है, मेनली increase in the direct bilirubin, and the hemolytic jaundice there is unconjugated bilirubin increase, so indirect bilirubin increase. मतलब टोटल बढ़ेगा, इनडायरेक्ट बढ़ेगा. यहाँ पे टोटल भी बढ़ेगा, इनडायरेक्ट भी बढ़ेगा, डायरेक्ट बढ़ेगा. टोटल मीन्स इनडायरेक्ट प्लस डायरेक्ट. यहाँ पे टोटल बढ़ेगा और डायरेक्ट बढ़ेगा, इनडायरेक्ट नहीं बढ़ेगा, मतलब थोड़ा सा बढ़ा हुआ रहेगा लेकिन एकदम ज्यादा बढ़ा हुआ नहीं रहेगा. So this is urinary urobilinogen. It is present in the hemolytic jaundice, urinary urobilinogen present, and it is absent in the, this can be MCQ, urinary urobilinogen present in the hemolytic jaundice. The bile salt, bile pigment, they can be present. The Fauchet test and the हेज सल्फर टेस्ट विच इज डन फॉर द, आप लोग यूरिन में करते हो फॉशेट टेस्ट, एंड द बाइल सॉल्ट के लिए क्या करते हो, हेज सल्फर टेस्ट। तो ये दोनों टेस्ट पॉजिटिव रहेंगी, मे बी इन द ऑब्स्ट्रक्टिव जॉन्डिस और हिपेटोसेलुलर जॉन्डिस व्हेन देयर इज माइक्रो ऑब्स्ट्रक्शन इज देयर, दैट्स व्हाई बिलिरुबिन appears in the urine, bilirubin appears in the uh, bile salt appears, bile salt and bilirubin, bile pigment, bile salt, they will give the positive taste in the hepatocellular or the obstructive jaundice. So this is how to differentiate between hemolytic, hepatic and obstructive jaundice, mainly on the basis of this bilirubin. अगर डायरेक्ट बढ़ा है मतलब कॉन्जुगेटेड बिलिरुबिन बढ़ा है मतलब ऑब्स्ट्रक्टिव कॉज है, इनडायरेक्ट बिलिरुबिन बढ़ा है जैसे नियोनाटल फिजियोलॉजिकल जॉन्डिस में इनडायरेक्ट बढ़ा रहेगा, सो इट मीन्स द हिमोलिटिक जॉन्डिस बिकॉज ऑफ इंक्रीज हिमोलिसिस ऑफ आरबीसी एंड इंक्रीज ब्रेकडाउन ऑफ हीम। एंड हिपेटिक जॉन्डिस में दोनों तरह का बिलिरुबिन बढ़ेगा, दोनों तरह का बिलिरुबिन बढ़ेगा, एसजीओटी एसजीपीटी लिवर स्पेसिफिक एंजाइम्स बढ़े हुए रहेंगे, मार्क रेज रहेगा उसमें। और एएलपी एएल दैट इज अल्कलाइन फॉस्फेटेज जीजीटी एंड 5 प्राइम न्यूक्लियोटाइड्स अगर बढ़ा हुआ है तो दैट इंडिकेट्स द ऑब्स्ट्रक्टिव जॉन्डिस। इसमें फ्लू लाइक सिम्टम्स बताएंगे कि उसको फीवर था, फ्लू लाइक सिम्टम्स थे, या तो हिस्ट्री बताएंगे कि बाहर का खाना खाया एंड ऑल। सो हिपेटाइटिस की जनरली हिस्ट्री रहेंगी, यहाँ पे पेन इन एब्डोमेन प्रोमिनेंट सिम्टम रहेगा इन द केस ऑफ ऑब्स्ट्रक्टिव जॉन्डिस। Hemolytic jaundice can be there in the G6PD deficiency. Hemolytic jaundice can be there in the sickle cell anemia, thalassemia. There is hemolytic jaundice, also galactosemia. There is hemolytic jaundice. So these are the different types of jaundice. These are the congenital hyperbilirubinemia. Now see the clinical case. A 31-year-old mother delivered a premature baby at 34 weeks of gestation. Baby cried well after birth. All reflexes were normal, but 3 days, this is important, but 3 days within 24 hour है तो pathological jaundice, RH incompatibility और ABO incompatibility may be the cause, लेकिन इसकी केस आपको जनरली आएगी नहीं, आपको केस आएगी नियोनाटल फिजियोलॉजिकल जॉन्डिस की। ओके, so but 3 days after birth mother observed yellow skin eyes of the baby. On blood examination indirect bilirubin level was found to be 11 milligram per deciliter. Indirect bilirubin means, indirect means unconjugated bilirubin levels 11 milligram per deciliter. What is your probable diagnosis? Hepatic obstructive jaundice, Gilbert syndrome, nothing like that. It is a simple case of physiological jaundice. It is quite common in the community. तो बच्चे को फोटोथेरेपी देते हैं, फोटोथेरेपी से क्या होता है, बिलिरुबिन इज कन्वर्टेड इनटू ल्यूमिरुबिन, सो द toxic bilirubin, toxic water insoluble bilirubin, it is converted into water soluble form lumirubin, excretable form of the bilirubin, and slowly it reduces the bilirubin level. So blue light 420 nanometer blue light it is given in the treatment, that is known as phototherapy, that is known as phototherapy. So this is the neonatal physiological jaundice. Jaundice appears on third day of life. There is increase in the indirect bilirubin level. Phototherapy is given in the treatment which converts bilirubin into non-toxic isomer and it is excreted through the urine. So this is neonatal physiological jaundice because of immature liver to conjugate the bilirubin, immature liver, because of rapid hemolysis after the birth, increased breakdown of heme is there, and immature hepatic capacity to conjugate that bilirubin, the bilirubin level increases, then that too indirect bilirubin, that is unconjugated bilirubin, that is known as neonatal physiological jaundice. Now see this case. A 63-year-old man came to hospital with complaint of abdominal pain. मैंने पहले ही बोला आपको abdominal pain. Pruritus, itching symptoms may be there because of increase in the bile salt level and yellow colored urine. Yellow colored urine. येलो कलर्ड यूरिन है, स्किन है, मतलब जॉन्डिस है, इतना तो पक्का है। एब्डोमिनल पेन की हिस्ट्री है, मतलब हो सकता है कि ऑब्स्ट्रक्टिव जॉन्डिस है, पहला अपने दिमाग में आना चाहिए। On laboratory investigation, blood test SGPT 81, SGOT 72, alkaline phosphatase it is 1286. There is mark raised in the alkaline phosphatase level. बिलिरुबिन देखो, अभी सबसे सिंपल बिलिरुबिन है, डायरेक्ट बिलिरुबिन 18 एंड इनडायरेक्ट बिलिरुबिन 2.1 मिलीग्राम पर डेसीलीटर। देर इज मोर इंक्रीज इन द डायरेक्ट बिलिरुबिन। सो ऐसे क्लियर कट पिक्चर कभी नहीं मिलेगा आपको, थोड़ा ना थोड़ा कंफ्यूजिंग रहेगा। देर इज मोर इंक्रीज इन द डायरेक्ट बिलिरुबिन, देर इज इंक्रीज इन द अल्कलाइन फॉस्फेटेज, देर इज एब्डोमिनल पेन हिस्ट्री। सी द एज, 63-year-old man. There may be a obstruction because of stone in the common bile duct, stone, stricture, tumor, tuberculosis of the common bile duct, or the carcinoma of the head of the pancreas that causes the obstruction to the flow of bile. So this is what is your probable diagnosis. Here this is a case of obstructive jaundice. Neonatal physiological jaundice तो रहेगा नहीं। यहाँ पे डायरेक्ट बिलिरुबिन बढ़ा हुआ है, नॉर्मल रेंज इज 0.2 to 0.4 मिलीग्राम पर डेसीलीटर डायरेक्ट बिलिरुबिन, ये बढ़ा हुआ है। ये भी थोड़ा बढ़ा हुआ है लेकिन दिस इज मच मोर रेज्ड। एब्डोमिनल पेन, प्रूराइटस इज देयर। एब्डोमिनल पेन, it is because of obstruction, and the pruritus, it is mainly because of the bile salt which causes the pruritus itching. So there is increase in the SGPT and SGOT, but there is slight increase in SGOT and SGPT, but there is marked increase in the alkaline phosphatase activity. Why ALP increases in the obstructive jaundice? Because this is an ectoenzyme. Ecto means present on cell surface, biliary surface of biliary canaliculi, and because of regurgitation of bile, there is release of this ALP from this biliary canaliculi and it enters into the serum. That's why there is increased alkaline phosphatase activity. Which of the following liver disorder is characterized by accumulation of conjugated bilirubin in the liver leading to black pigmentation? Black liver jaundice, black pigmentation. It is Dubin-Johnson syndrome. It is because of mutation in MRP2 protein और मल्टी स्पेसिफिक ऑर्गेनिक एनायन ट्रांसपोर्टर, उसको ही बोलते हैं ABCC2 प्रोटीन, which is required for active transport of bilirubin into bile canaliculi. Dubin-Johnson syndrome, there is increase in the direct bilirubin, that is conjugated bilirubin increases. conjugated bilirubin बोले बराबर क्रिगलर नजर कट गया, गिलबर्ट कट गया, दो ही बचे, डुबिन जॉनसन, रोटर। एंड black pigmentation, it is in the Dubin-Johnson syndrome. This can be MCQ for your examination. So this is all about the heme synthesis and the bilirubin metabolism. Now we'll discuss the important, that is sickle cell anemia, thalassemia. We'll discuss different types of hemoglobin that we will discuss. Okay. So just wait. So see, hemoglobin, it is degraded to heme and globin. Heme is the prosthetic group in the hemoglobin structure. It is protoporphyrin 9 with iron at its center. Globin is the protein part. There are two types of globin chain, alpha globin chain and beta globin chains. Alpha with 141 amino acid, beta with 146 amino acid, total 574 amino acids in the structure. Two alpha chain, two beta chain in the hemoglobin structure. These are the normal hemoglobins. Hemoglobin A1, A2, that is adult hemoglobin. This is 90% hemoglobin A1, alpha 2, beta 2. Hemoglobin A2, alpha 2, delta 2, less than 2%. Hemoglobin AF, it is normal in the fetal life, that is alpha 2, gamma 2, but in adult it is less than 2%. And the attachment of glucose to N-terminal valine of the beta globin chain causes the production of glycated hemoglobin, that is non-enzymatic attachment of glucose to the N-terminal valine of the beta globin chain that produce the glycated hemoglobin, which is less than 5%. In diabetes mellitus, it is more than 5.5%. It indicates the diabetes, means it indicates the level of glucose, average level of glucose for preceding 3 months, 2 to 3 months, depending on the RBC lifespan, that is 120 days. And these are the hemoglobins in the embryonic and fetal life, that is Portland, Gover 1 and Gover 2. This is oxygen hemoglobin dissociation curve. This is partial pressure of O2 on the x-axis, and the y-axis there is hemoglobin saturation, percent saturation. So it is sigmoidal in shape because of cooperative binding of O2 to the hemoglobin molecule. Cooperative binding means each subsequent O2 binds to the hemoglobin with much more affinity. The with much more affinity. So cooperative binding मतलब एक बंदा आगे जा रहा तो बाकी के बंदे भी मतलब वो बंदा बाकी के बंदों को हेल्प कर रहा आगे जाने के लिए, पैर नहीं खींच रहा उसके. सो दैट इज कोऑपरेटिव बाइंडिंग. इट शोज द सिग्मोइडल शेप ऑक्सीजन dissociation curve. So this negative effectors causes the loading of oxygen to the tissues. Negative effector causes decreases the binding of O2 to the hemoglobin. For example, decrease pH, increase in the CO2 level. At the tissue level there is increase in the CO2 level. 2,3-bisphosphoglycerate, this is an important compound intermediate of the glycolysis, product of Rappaport Lubering cycle. There is production of 2,3-bisphosphoglycerate. This occupy the central cavity of the globin chain. It is negatively charged molecule. It attached to the positively charged lysine and arginine, and it decreases the affinity of O2 to the hemoglobin. That's why it is responsible for releasing the O2 to the tissues. So it shift the oxygen dissociation curve to the right. So this compound shift the oxygen dissociation curve to the right. So 2,3-BPG is an important compound. It decreases the binding of O2 to the hemoglobin, causes the supply of O2 to the tissues. So this is very very important. This is important in the high altitude hypoxia, chronic obstructive pulmonary diseases. It is important, and it is not present in the fetal hemoglobin. It is present in the adult hemoglobin. So this is important in transport of oxygen from mother to the fetus. Now we'll discuss the important case, that is sickle cell anemia, and we'll discuss the important features in the sickle cell anemia. Now see, a 5-year-old boy brought to the pediatric OPD with chief complaint of fatigue, breathlessness, and pain in the extremities. Fatigue, breathlessness, and pain in the extremities. On examination, he was found to have pallor. Pallor means decreased hemoglobin, jaundice, and splenomegaly. Peripheral blood smear examination revealed presence of sickled shape RBCs. So there is sickled shape RBCs. Explain the molecular basis of sickling, मतलब sickled shape RBC क्यों होते हैं, and explain the pattern of inheritance. Pattern of inheritance, it is autosomal recessive. तो autosomal recessive का pattern निकालना पड़ेगा आपको. And explain the molecular basis of sickling. This starts with the point mutation. This starts with the point mutation, molecular basis of sickling. Okay, we'll discuss करेंगे ये भी. A 13-year-old apparently normal boy, मतलब उसको ज़्यादा symptomatic नहीं है, went mountaineering. He developed acute breathlessness and was found to be slightly anemic upon examination. Laboratory investigation showed AS pattern in electrophoresis. Name the clinical condition. Name the laboratory test done for its diagnosis. ये दोनों point हम discuss करेंगे. See, what is the molecular basis of the sickle cell disease? Molecular basis. Sickling क्यों होती है? Molecular basis of sickle cell anemia. Here there is point mutation. Point mutation, partially acceptable missense point mutation. Partially acceptable missense point mutation. See, at the DNA level, there is CTC. So here thymine is there, which is replaced by the adenine. So CTC, it is replaced by the CAC at the DNA level, which is at the RNA level means the GAG, it is replaced by the GUG. A is adenine is replaced by the uracil. So this GAG code for glutamate and GUG code for the valine. So at the sixth position of beta chain, the glutamate, it is replaced by the valine. So glutamate, it is acidic amino acid. It carries the negative charge. So it is polar amino acid. Polar amino acid. This polar, it is replaced by the non-polar valine. It is replaced by the non-polar hydrophobic amino acid valine, carrying the less negative charge. So that because of this, there is formation of hemoglobin S, which is uh, less soluble and more precipitable form. less soluble, more precipitable form, that is hemoglobin S. So hemoglobin A is converted into hemoglobin S because of glutamate replaced by the valine at the sixth position of beta chain. So hemoglobin A, it is replaced by the hemoglobin S. This is because of partially acceptable missense point mutation in which the GAG, it is replaced by the GUG. GAG codes for the glutamate, GUG code for the valine. Glutamate is replaced by the valine at the sixth position of beta chain. Now this is autosomal recessive inheritance. If father is a carrier and mother is also a carrier, means having the AS pattern, only one gene is affected in father, only one gene is affected in the mother. If it is heterozygous state, both are heterozygous state, uh, autosomal recessive inheritance. If there is autosomal recessive inheritance, see, autosomal recessive inheritance, AS, AS. So there is, see the pattern, A, AS, AS and SS. So there is 25% chance of having the unaffected child, the 50% chance of having the carrier, 50% chance of having the carrier, and the 25% chance of having the diseased child with SS pattern. Diseased child with SS pattern. So this is autosomal recessive inheritance. कहीं पे भी autosomal recessive का inheritance पूछा तो same आएगा. Okay, so this is autosomal recessive inheritance pattern. Now what is molecular basis? That is, because of point mutation, the glutamate is replaced by the valine. The water soluble means the polar amino acid is replaced by the non-polar hydrophobic amino acid, which is which forms the hemoglobin S, which is less soluble and more precipitable form. So deoxyhemoglobin S, hemoglobin S, when it is in deoxygenated state, जब deoxygenated state में रहेगा, the it is precipitate in the infection at high altitude, in the exertion. When it is in the deoxygenated state, deoxyhemoglobin, there is sticky patch, the valine gives, glutamate is replaced by the valine. So valine gives, hydrophobic amino acid gives sticky patch to the deoxyhemoglobin S. Also there is complementary receiving patch is also there in the deoxyhemoglobin S. So this fits into one another and they form the long polymer. They form the long polymer. So there is formation of polymerization of deoxyhemoglobin S occurs, which form the fiber, which forms the fiber, and this fiber distort the shape of the RBC into the sickled shape. This fiber distort the shape of the RBC into the sickled shape RBCs, and this sickled RBCs in the capillaries, narrow capillaries, they block the flow of the blood. So distal to the flow there is damage. मतलब ये ब्लड सप्लाई नहीं होगा तो ये आगे का पार्ट डैमेज हो जाएगा. सो इट ब्लॉक्स द माइक्रोवास्कुलेचर. दैट्स व्हाई पेन in the extremities is the predominant feature in the sickle cell disease. So there is anemia, there is jaundice, there is anemia and breakdown of RBCs because of sickling. It causes the breakdown of heme and bilirubin production. So there is anemia, there is jaundice, there is splenomegaly, and there is pain because of obstruction to the flow of the blood. So there are sickling test is done, which is screening test. That is, peripheral blood smear is prepared by using the sodium metabisulfite or sodium dithionate, and demonstration of sickling under the microscope is done, which is a screening test. And this is electrophoresis, hemoglobin electrophoresis pattern, electrophoresis, which is done by using the gel electrophoresis or the cellulose acetate membrane electrophoresis. So in electrophoresis, this is normal. Normally the hemoglobin A is much more. Now in the sickle cell trait, there is hemoglobin A band is there and hemoglobin S band is there. A and S both band is there. So this is known as AS pattern. This is known as AS pattern. If there is AS pattern, it is known as sickle cell trait. And if there is single band of hemoglobin S, there is no hemoglobin A. So hemoglobin S is there. So it is known as sickle cell disease. No A band is there. So it is known as sickle cell disease in the hemoglobin electrophoresis. So this is all about the sickle cell anemia. Frequent blood transfusion is needed. Hydroxyurea is given, and some that is stem cell transplantation, bone marrow transplantation, and this will give the promising results. Okay. Now the sickle cell anemia is the hemoglobinopathy, and it is due to mutation, and that produce mutated protein. There is production of mutated protein. Here thalassemia, it is because of decreased production of the globin chain. It is because of decreased production of the globin chain. It is quantitative defect. Thalassemia is the quantitative defect. In the thalassemia, there are two types: alpha thalassemia and beta thalassemia and alpha thalassemia. So you may get a case of beta thalassemia major, which is important one. So thalassemia, two types, main types: alpha thalassemia and beta thalassemia. There are four types of alpha thalassemia and two types of beta thalassemia. Alpha thalassemia, see, two alpha genes on the chromosome 16, four alpha globin alleles that produce four alpha mm, that produce four alpha genes. Okay, so depending upon the missing of alpha genes, there are four types of alpha thalassemia. Four types of alpha thalassemia. So suppose alpha, this is four genes for the alpha chain production, four genes. Okay. Now, when one gene is missing, there is no symptoms. The other three will compensate. There are no symptoms. It is known as silent carrier. Alpha thalassemia, silent carrier. When one gene is missing, when two genes are missing, there is mild anemia. There is mild anemia. That is known as alpha thalassemia trait. That is known as alpha thalassemia trait. When three genes are missing, when three genes are missing, there is compensatory formation of the beta tetramer. Beta tetramer formation is there, and this gives mild to moderate anemia. Moderate anemia, it is known as hemoglobin H disease. Hemoglobin H disease. And when all four alpha genes they are missing, so there is formation of gamma tetramer and it precipitates the RBCs. So hydrops fetalis, stillbirth can be there. Fetal death occur at the birth. Fetal death occurs at the birth. Hydrop fetalis, there is formation of gamma tetramer. In the hemoglobin H disease, there is formation of beta tetramer. So thalassemia, alpha thalassemia, when alpha globin gene means decrease alpha globin gene, that this is known as alpha thalassemia. This is quantitative defect. There is no defect in the quality. There is quantitative defect, decreased production of the globin chain, alpha globin chain synthesis. That is known as alpha thalassemia. And beta thalassemia means there is decreased synthesis of beta globin chain, decreased beta chain production. There are two genes. If both are affected, it is defect in both the gene, it forms the homozygous state, that is known as the beta thalassemia major, and it is the severe condition, beta thalassemia major. There is no beta chains, no formation of beta chains. So hemoglobin, there is no hemoglobin A or the very low hemoglobin A, or no hemoglobin A. So there is, this is alpha 2 gamma 2, so there is increased hemoglobin F. This is alpha 2 delta 2, so there is increase in the hemoglobin A2 concentration. There is anemia, there is jaundice, there is hepatomegaly, splenomegaly, there is phases, that is frontal bossing, maxillary overgrowth will be there. The because of hematopoiesis in these flat bones, that gives the phases, thalassemic phases appearance, that is frontal bossing, maxillary overgrowth, that is known as thalassemic phases. And X-ray skull shows the hair on end, appearance in the X-ray skull. So this is skull. X-ray will show the hair on end appearance. So this is known as X-ray hair on end appearance. Hair on end appearance on the X-ray. This is in the thalassemia, beta thalassemia major. Both the genes, defect in both the genes, beta thalassemia major. Okay. Also electrophoresis, then the capillary electrophoresis, HPLC, these techniques are important for estimation of this different hemoglobin levels, concentration of this hemoglobin level. So there is low activity, very low activity or absent hemoglobin A, increased hemoglobin F. increase hemoglobin A2. Anemia, jaundice, hepatosplenomegaly will be there. Thalassemic facies, hair on end appearance, these are the features. This is minor, beta thalassemia minor, as the name indicates, single gene is defective. There is decreased hemoglobin A, increase hemoglobin F, increase hemoglobin A2. So there is hemoglobin A activity is there. That's why symptoms are less as compared to beta thalassemia major. So this is all about the thalassemia. So this is all about the thalassemia. Now, for the diagnosis of the hepatocellular and obstructive jaundice, we do the H sulfur test. Obstructive jaundice के लिए H sulfur test और Fauchet test हम लोग करते हैं. Now the different hemoglobin derivatives. Hemoglobin derivatives. So there are normal and abnormal hemoglobin derivatives. So normal hemoglobin derivatives, it includes normal. Normal hemoglobin derivative, it is oxyhemoglobin. When oxygen molecule is attached to hemoglobin, it is known as oxyhemoglobin. Deoxyhemoglobin, when it is delivered to the tissues and there is no oxygen to the hemoglobin attached, oxygen is not attached to hemoglobin, it is known as deoxyhemoglobin. Then carbamino hemoglobin, it is when CO2 attached to hemoglobin, it is known as carbaminohemoglobin. So oxyhemoglobin, deoxyhemoglobin, and the carbaminohemoglobin, these are the normal hemoglobin derivatives. The abnormal hemoglobin derivatives, abnormal, it includes meth hemoglobin. So here in the meth hemoglobin, the iron is in the ferric state. Iron is in the ferric state, so it is not able to bind with the oxygen molecule. So it is known as meth hemoglobin. And this abnormal hemoglobin can be diagnosed by doing the absorption spectral examination can be done. Spectral examination of blood can be done. So meth hemoglobin, it is formed by the various drugs. Various drugs can form the meth hemoglobin. Also the reactive oxygen species means free radical and various drugs, they are responsible for the formation of methemoglobin. Also when there is congenital defect in the methemoglobin reductase enzyme that can cause the methemoglobin formation. So this is one abnormal form. Then second one is the carboxyl hemoglobin, that is attachment of carbon monoxide to the hemoglobin, it is known as carboxyl hemoglobin. This is by the industrial pollutant or cigarette smoking that causes the carbon monoxide to bind with the hemoglobin, and it has 200 times more affinity to binds with the hemoglobin molecule. And if carbon monoxide is concentration is little higher in the environment, it can cause toxicity, carbon monoxide. So it has very high affinity for the hemoglobin binding sites. That's why carboxyl hemoglobin is dangerous. So it is automobile fuel and the cigarette smoke, carbon monoxide is there. It initial stages it can cause nausea, dizziness, vomiting, but when high concentration is there, it can cause the serious effect, and hyperbaric 100% oxygen therapy is needed for this poisoning, carbon monoxide poisoning. Third one is the sulfhemoglobin, or the fourth one is the cyanohemoglobin. So this is when the poisoning is with their H2S poisoning, and it can cause the cyanosis. And cyanohemoglobin, it is when the cyanide poisoning is there, there is formation of cyanohemoglobin. So bluish discoloration, cyanosis will be there. So these are the abnormal hemoglobin derivatives. You may get a short note on the hemoglobin, normal hemoglobin molecules and the hemoglobin derivatives. Normal hemoglobin matlab hemoglobin A1, hemoglobin A, hemoglobin A2, hemoglobin F, and HbA1c. And abnormal hemoglobin derivatives बोला तो normal hemoglobin derivatives, abnormal hemoglobin derivatives. Abnormal hemoglobin बोला तो hemoglobin S, hemoglobin C, hemoglobin M. These are the abnormal hemoglobin. Normal hemoglobin, hemoglobin A, hemoglobin F, Glycated hemoglobin, hemoglobin A2, these are the normal hemoglobin. Abnormal hemoglobin, hemoglobin S, hemoglobin C, hemoglobin M. Mutation, by the mutation, these are the hemoglobin derivatives. These are the hemoglobin derivatives. So this is all about the hemoglobin chemistry. What is hemoglobin? What is porphyrin? Sickle cell anemia, that is hemoglobinopathy, normal hemoglobin, abnormal hemoglobin, normal hemoglobin derivative, abnormal hemoglobin derivative, in short about the oxygen dissociation curve. Hemoglobin metabolism, that is the heme synthesis and porphyria, bilirubin metabolism and the different types of jaundice associated with bilirubin metabolism, congenital causes, three different types of jaundice. We discussed all these things. So this is very important chapter for the clinical cases, very important, very important chapter for the LAQ, very important chapter for the clinical cases and short note. So this can be asked in your university examination. So this is all about the hemoglobin chemistry and metabolism. So thank you very much for the patient listening. Revise the topic, prepare for the topic. This is must know topic for your university examination. So hello Anurag, thank you. Yuvraj Singh, Vinay. So thank you, Sonu, Varadraj, Brumil, Mitanshu, Shantanu, Raghav, Dinesh. Thank you all of you. Thank you very much all of you. अच्छे से पढ़ो, प्रैक्टिस करो, लिख के देखो, डिस्कस करके देखो अपने रूममेट के साथ, अपने फ्रेंड्स के साथ, एंड प्रिपेयर फॉर द बायोकेमिस्ट्री. अच्छे मार्क्स लाओ. थैंक यू वेरी मच ऑल ऑफ यू.